sleep restriction or compression. So that's the brief behavioral therapy, which is also very effective. The problem is sleep physicians, maybe like Dr. Ramakrishnan, he's doing critical care, he's doing sleep medicine, seeing all these patients, he may not have time even if he's trained. So we need to train other people, psychologists and nurses. Nurses, if you spend time with them, incorporate them in your group and team and educate them, they can be very good resources for administering CBTI. Because what happens when you don't is a lot of medications are being used and multiple medications are being used. So training people to do CBTI is important. So pharmacotherapy. I'll try to go through this fast and just give the broad perspective. One is there's no practice parameters published. Illness, especially when pain is present. Jet lag and shift work can be helpful sometimes. But whenever you give these medications, ongoing assessment and monitoring is extremely important. What I've seen in India, a lot of people take a medication from a doctor and they feel they have the medication so they don't have to go back to the doctor. So be careful of prescribing medications to these patients because then they go to another doctor, they give them another medication, and they take both medications without telling either doctor what the other doctor gave them. So you have to be acting benzodiazepine or benzodiazepine receptor agonist, such as zolpidem, azobiclone, zaloplan, or temazepam. And the guidelines also say Rimeltian, which is a melatonin agonist, but nobody's had, none of my colleagues, none of the studies have actually shown it to be effective. If that doesn't work, use another medication in that group, and or sedating antidepressant. Sedating antidepressant is number 3 because of the lack of studies. However, the chance for doing these studies has not been fair because the drug companies are what actually sponsor the studies. So I think these were taken out of the picture very early before they've been given a fair chance. Combination therapy with one or more. Other sedating agents, and if you see atypical antipsychotics are here, but if you notice it's not number 1, number 2, number 3, or even number 4. So this should be a last resort in patients with comorbid illness, and it shouldn't be a first-line therapy at all, but still, many people use these medications as first-line therapy. So I think later in the day, Dr. Manjari is going to be talking about a lot of these medications. Just a few things. Clonazepam is not indicated, but if you have sleep-wake transitions or significant anxiety associated with insomnia, it can be tried. Suvorexant, and the other thing I want to say, a lot of these medications aren't available in most pharmacies, especially the trazodone. So if you want to use trazodone, talk to the pharmacies that you may be working with to make sure they get it, because it is available in India. Since we've started our hospital, trazodone is available, has less anticholinergic side effects, and it's actually a pretty good medication. So amitriptyline is available, trazodone is not. So if you want to use any medication, make sure that the pharmacies you work with have these medications. One other point I want to make, this is the GABA benzodiazepine complex, has 5 subunits. The main difference between the agonists and the benzodiazepines is the agonists all have subselectivity towards A1, which is specific for sedation. This is important because if you use medications that act on all, then even though these effects are not bad, there's more tolerance, there's more addiction, there's more withdrawal. The last thing I want to say is there's a lot of people that still use benzodiazepines. Temazepam is the only one that should be used. I've had patients come in on flurazepam and look at the half-life. So these medications should not be used for insomnia. And if you want temazepam, also talk with the pharmacist and make sure they have temazepam. This Dr. Manjari will be talking about, so I'm going to skip this. Sedating antidepressants, the trazodone, the mirtazapine can be, if the problem with mirtazapine is that you have to check CBC for the neutropenia. That's why it may not be used first time, but both of these help. Doxepin has to be low dosed, and amitriptyline is very good for sleep, except that it has more anticholinergic side effects than the trazodone. Use of hypnotics in elderly. Use the lowest possible dose of the medication when you need to, and use a single dose as far as possible. and use intermittent dosing when possible, and avoid mixing it with alcohol and other.
So thank you, everybody. We'll close the morning session now. We'll have a 10-minute tea break, and then the audience will be split into two halls. So hall 2, or the hall where the neuropsychiatric disorders are being discussed, is the hall right across from here, the opposite hall. And then hall 1, where the respiratory disorders and sleep are being discussed, is the one across the foyer. So 10 minutes tea break, and then let's reassemble in the respective halls for the post-tea session. Thanks.